Assalamu alaikum. This is Dr. Saima Seher, and today I'll discuss SPECT MPI and myocardial blood flow quantification. SPECT MPI, as we all know, is an established non-invasive method to evaluate patients with no known or suspected coronary artery disease. Its diagnostic and prognostic significance is supported by a wealth of clinical and observational trial data. The problem that we face in regional perfusion analysis is global reduction in myocardial perfusion in patients with TVCAD that results in balanced ischemia and hence a false negative scan. So, this challenge is now appropriately addressed with very exciting advancement in nuclear cardiology, that is absolute quantification of myocardial blood flow and myocardial blood flow reserve. So, what is myocardial blood flow? This is absolute amount of blood that myocardium receives in milliliter per minute per gram of the tissue. And myocardial blood flow reserve is the ratio of myocardial blood flow at maximal coronary vasodilatation to blood flow at rest. Now, what's the lead of this new quantitative parameter? Actually, when we incorporate MBF and MBFR estimation along with conventional SPECT MPI, this improves the diagnostic accuracy of this testing procedure with better estimation of extent and severity of disease that results in improved assessment of risk stratification. And all these features and factors, they help in better selection of patients for coronary intervention and or medical therapy. Then those patients who have got balanced ischemia and a false negative scan, this can be picked up by reduced MBF and MBFR. In most of the centers, high volume centers, almost 10% of the patients have false negative scan because of vasodilator failure. 10% is a big number. And with the help of this new quantitative parameter, we can also find out those patients who have got a normal scan because of vasodilator failure. Then this can help us in detection of coronary microvascular disease. All this additional information is achieved without having any extra radiation exposure to the patient. We don't give any extra MCI of radiotracer. Imaging time is though a bit prolonged. So just a comparative analysis, MFR allows us to non-invasively evaluate the entire coronary delivery system. It includes macrovasculature and microvasculature. So what's the prerequisite for this estimation? For MFR and MBF quantification, we require CZT-based cardiac dedicated gamma camera, which is equipped with a software for this MBF and MBFR quantification. It's an expensive and high-tech equipment, and AFIC is the first institute in Pakistan that procured this highly sophisticated machine, and we are doing MBF and MBFR quantification in routine along with SPECT MPI. So the difference is it's a combination of dynamic and static imaging. When the tracer is injected, dynamic imaging starts. It tracks the tracer through right side of the heart, right heart cavities, lungs, left heart cavities, and then into the myocardium. So our time activity curve is generated. These are the quantification software, QPS, QGS, and NVR4DM corridor. This also helps us in estimation of left ventricular volumes, ejection fraction, and all. So, if global MBFR is more than 2, this is considered as normal, and this places the patient in low risk category. 1.7 to 2 is mildly abnormal. 1.2 to 1.7 is quite abnormal, and that places the patient in high risk group. Now, if MBFR is less than 1.2 with multiple perfusion defects, this is this places the patient in very high risk category. The result is highly abnormal. Whereas if the scan is normal and MBFR is reduced, there can be multiple reasons for that, and I'll explain it in a while. There are multiple factors that can affect MBFR estimation. Technical factors are the type of radiotracer that we use. Different tracers have got different extraction fraction, type of accusation scheme, and the quantification model. Then physiological factors are the type of stress, resting blood flow, and completeness of preparation. Then diabetes, hypertension, obesity, these are the other factors that can affect the value. I'll explain it with the help of few clinical cases. A 49 years old lady presented with chest pain. Her only CAD risk factor was dyslipidemia, and the scan was done. Her myocardial perfusion was normal, and stress myocardial blood flow and myocardial blood flow reservoir was also normal. So it's an absolutely normal scan, and this places the patient in low risk category. Then a 72 years old gentleman, he had atypical chest pain for last 6 months, not responding to any medical therapy. His calcium score was high and he was referred for cardiac evaluation. His scan was normal and the scores were normal. There was no TID and there was no fall in ejection fraction. Like, we couldn't find any poor prognostic marker in the scan. But his stress MBF and MBFR was reduced globally and in all the 3 territories. So high calcium and reduced MFR. This requires further investigation. So coronary angiography was done. The patient had TVCAT, critical TVCAT, and afterwards CABG was done. So these are the cases. These are the causes. Number 1 is multivessel coronary artery disease. Balanced ischemia, जो कि हमें बहुत problem मिलती है, because we get a normal scan and we say the scan is normal, and the cardiologist says, "Can't you see the lesion?" So we can, fight with that thing with the help of this MBFR and MBF quantification. Then coronary microvascular disease. We can get a normal scan and reduced MFR in patients who have got coronary microvascular disease. Then in patients who have combination of moderate epicardial coronary artery disease along with microvascular disease. And then in those patients who have got vasodilator failure. This is a 59 years old gentleman, a known diabetic, presented with chest pain. When the scan was done, he had moderate to severe reversible ischemia involving infralateral and adjoining anterolateral wall. But his MBF and MBFR was reduced in all the 3 territories. When angiography was done, the patient had TVCAT. So the disease was not confined to one artery, the patient had TVCAT. So this is how this new quantitative parameter helps us in better estimation of extent of and severity of disease. Then this was a patient who had vasodilator failure. The scan was normal. Stress MBF and MBFR was reduced. When he was inquired again, then he told us that he smoked in the morning. So this was a serving soldier, a 35 years old gentleman who presented in evening an emergency of AFIC, and he had chest pain. So his angiography was done within few hours, which turned out to be normal. But the patient was symptomatic. His myocardial perfusion was normal, but his, again, stress MBF and MBFR was reduced. So this patient is likely is having that coronary microvascular disease. MBF and MBFR has got very high negative predictive value. So if the scan is slightly abnormal, but these values are normal, there are less likely chances that we get some significant disease on angiography. So what are the important practice points? Number 1 thing is this helps us in identifying patients who have got balanced ischemia. Second thing is that we can identify those who have got a normal scan because of vasodilator failure, and the scan can be repeated with proper preparation. Similarly, if anatomy is normal, if perfusion is normal and MBFR is reduced, this goes in favor of microvascular disease. Again, one point is that this can help us in enhanced detection of viable myocardium. If the blood flow is 0.6 milliliter per minute per gram, it means that the area or the segment is viable. This gives us an additional information. So if global MBFR is more than 2, this is highly reassuring and this places the patient in low risk group. If there's low MBFR and the patient has no known history of coronary artery disease, further investigations are needed. Lower the MBFR, more are the chances the patient has got multivascular disease. So the take-home message is that MBF evaluation provides complementary information to conventional MPI that adds value of the testing procedure in diagnosis, quality assurance, and risk stratification. Thank you. Any questions?